Okay, is everybody ready? We're just about to begin the Health and Wellbeing Board meeting for December the 7th, 2023. Item number 1, can I have, first, welcome everyone. Hi, I hope you're all doing well. And for those councillors that got in late last night, for that long full council meetings, welcome, and everybody else. Okay, so first, apologies of absence. Now I have Councillor Karecki, the leader, Sally Dehan, if I'm pronouncing it right, Michael Bell, Florence Kroll. Oh, Michael Bell has been replaced. Am I right?
Chair, I understand that Michael Bell has been replaced as the representative of the Lewisham and Greenwich Trust.
Okay.
But I haven't been told which of those two individuals' names have got on there.
Oh, okay.
But neither of them are here anyway.
Okay, all right. We have Florence Kroll and Sarah McClinton. Those are absent. Any more apologies for absence before I go to apologies? Any other apologies? Okay. And I have one, so I've received 2, but I've one down here, apologies leaving early, Anne-Marie, Councillor Cousins, leaving early, and Matt Morrow. Councillor Matt Morrow, leaving early. Anyone else? Any other apology? Okay. All right. Item number 2, I have there is no urgent business. Item number 3, declaration of interest. Do members have any declarations of interest? Okay. Number 4, minutes of the last meeting. So those meetings have been published and circulated. Are there any, are they accurate? Yeah. Can I sign them off? All right, so I'm going to sign them off. Okay. Next, we go on to item number 5, the Healthier Greenwich Partnership Local Care Plan Activity Progress Update, presented by Neil. Welcome, Neil.
Thank you very much. Good to see everyone today. I hope you're keeping well. So the paper, I'm going to take the paper as read, but just to remind people, back in July's meeting, we signed off the Health and Wellbeing Strategy, which is the strategy for the borough across the health and care system with an underpinning delivery plan for the next 5 years. And we said we'd be updating that delivery plan on a regular basis. But overall, sort of those priorities are there for the next 5 years. And at the top of, in the appendix, the slide which highlights sort of Live Well Greenwich, starting well, being well, feeling well, staying well, and aging well as that kind of overarching banner with the 10 priorities under that. And then in the detail of that, we've got then the health and care plan where we've got over 3 priorities against each of those 10. So that, do the maths right, that's 30, and it's actually 32 in total that we've got as kind of key priority areas. And what this board report does is just highlight some of the progress that we have made. So we've done our first 6-month review into that, which we've taken through the Healthy Greenwich Partnership, which is our kind of delivery partnership working together on this. So I just wanted to share a few highlights really from that. So overall, the good news is much is on track. So 16 high impact activities are all on track, and 16 high impact traits are deemed at risk. That means that there's some, it's not that they're not going to happen, but it's just that there's some delay in achieving where we would hope to get to in that first 6-month period. And really section 4 of my paper really highlights where we've made some good progress. So I won't read it all out to you, but I just want to sort of draw a couple of attention to a few things. So under the Start Well, we've now had 3 of our family hubs launched. We're going to have 4 in total, but 3 already launched. Our new integrated therapy services is fully in place. And we're doing a lot of work on autism spectrum disorder around kind of the gap analysis, what we need to do to secure additional support, working with Oxley's and getting additional funding in. We know there's basically too long a wait for people wanting those assessments. The other thing to really highlight, which is fantastic, is the send-in inspection. So we got the top rating where children typically get a good result from our SEND services. And that is not just education, that's the local authority, social care, it's education, it's health, it's all of those aspects working with our schools. So that's really great, and they highlighted some really good practice. We're one of very few in the whole country that's got that top rating. That doesn't mean we're complacent, because the top rating is typically, that doesn't mean every child gets the best outcome, and what we need to do is continue to improve, and we've got our SEND strategy development in place at the moment, but that's really good. Under Be Well, and the next two areas, lots going on around activity, and as people know, Steve Whiteman, the overall sort of public health report this year has all been on physical activity and the importance of that, and we've talked about that here. And so that work is continuing, and one of the things we're doing is a 100-day challenge, working with schools, so particularly looking at how do we get our children to be more active. And so of the 100-day challenge, we're now 25 days in, so we're a quarter of our way through that. We've already completed one 100-day challenge, which is all on cardiovascular care. We've had a significant uptake in kind of blood pressure monitoring, and some of that work is continuing. We've done some really exciting work in Glindon, and we're starting to see the benefits of that. So on the Be Well side, lots going on there. On the Feeling Well side, lots going on kind of tobacco, drug work as well, that's really important, as well as a lot of work going on our mental health work. And so we've put more resources into our specialist CAMS provision and making sure we're trying to reduce the numbers waiting, but we know there are still some people waiting over 52 weeks, which is obviously too long, but we're also got the Greenwich Mental Health and Wellbeing Hub fully live in Plumstead Health Centre, and I think we've said if people want to go out and see some of these services and how they're working, but I think there's over 50 staff, and that was one of the things that we'll talk about in the informal Health and Wellbeing Board, because that was presented there. It's probably worth noting, and maybe Steve will want to say something, but obviously the government announcement about trying to eradicate smoking overall, obviously is quite a big national opportunity to make a significant difference, because smoking is still such a major determinant, unfortunately, of people's ill health. A lot of work going on the Stay Well agenda around trying to kind of improve access and capacity in many different parts of the system, and so we've got a lot of there's some detailed updates in there. I'm not going to go through all the details of that, but a lot of work going on cancer screening in particular, and trying to improve that uptake, and particularly targeting people who haven't generally engaged in cancer work, and to improve that going forward. And then lastly, a lot of work going on with Age Well. So we've now got our new home care provider contracts being mobilised. We had a really successful kind of carers strategy kind of 1 year on from our strategy launch session a few weeks ago, and moving that forward. And kind of one of the things that sort of spans both of that is work on autism. So we had our kind of relaunched Autism Partnership Board on Monday of this week, where we're going to really develop an all-age autism strategy, knowing that there's a lot we need to do nationally. It's a national issue, but what are we going to do here in Greenwich? So section 5 really, so that essentially there's a lot to celebrate in terms of good progress, which is really encouraging. I think what the Health and Wellbeing Board probably want to know is, well, what outcomes have we achieved from this? And just to remind people, this is the 5 year, so I haven't got the detail on what the outcomes are yet, because this is work that we do, and we see the outcomes over time. But just to highlight that we will come back and update on here. But in terms of the lessons learned, I think there's some really important points around kind of the strength of partnership working is absolutely critical to everything that we do. And I think we're really seeing the benefits of having that integrated commissioning kind of coordination functions for adults and children's coming to bear. A lot of work around that whole co-production and community engagement work. And it was good yesterday to be at the G-Hive event and kind of just recognising the importance, only 20% of health outcomes are going to be delivered through the quality of the healthcare services you have. It's about those wide determinants of health and basically making sure we do that joined up work with our communities. I think what's really helpful to know is on the unified approach to change that we've got a real sort of sense of people wanting to work together and having a common plan. So if you work in children's services or in adult services, it's not like you've got a local authority plan and then you've got an NHS plan to deliver, and then you've got a plan that's been set from a national level. The idea is that there's just one plan. So in a sense, it means you're not kind of trying to feed multiple different masters. So I think we're starting to see that. I think resourcing is always a challenge for workforce, and I think it's one of the overall things, and we've obviously got an update on social care workforce as part of this work, and making sure that our kind of knowledge and data is all in place. I'm not going to go through every other point on here, but I just wanted to kind of summarise at that point about some of those key messages, but happy to take any questions, and I don't know, Steve, is there anything you want to add at all?
Thank you. I'll add a couple of things to what Neil has said. Firstly, on the physical activity and the second of the 100-day challenges that Neil mentioned. So that's got a focus on children and young people, and there's 3 different work streams sitting under that. One is around early years, working with children's centres and other early years settings. And looking at particularly around kind of training the workforce and developing people's confidence and capacity to build physical activity opportunities into sort of everyday life within those settings. The second is similarly around primary school settings, and the third is around working with teenage girls. We know from data that young people's physical activity levels remain at a sort of relatively consistent level, apart from in the teenage girls, where they tend to drop off in the kind of mid-teenage years. So doing some insight work with groups of young women around what that might be about and what might make a difference. On the smoking front, Neil mentioned the Smoke-Free Generation initiative that's come nationally. Part of that is a sort of policy agenda around trying to raise the age at which it's legal for young people to buy cigarettes, such that anybody born from 2013 onwards will never legally be able to buy cigarettes in this country. So quite a bold policy, and one that's part of a consultation that closed yesterday, so a national consultation on a series of policy measures that government have put out through the DHSC. Lots of people will have responded to that. Some of them will be supportive. The tobacco industry will have been lobbying hard to try to scupper those policies from getting through. What is clear, though, is that there is new money, and that's coming despite what may come through the consultation that happened yesterday. So every local authority is getting some significant additional resources to further develop their tobacco treatment services and the offer to help people who want to quit smoking to do so effectively. I co-chair a South East London tobacco group, and we've been talking a lot about what we might do collectively as well as at a borough level to enhance our offer. We're also looking at doing further work with our NHS trust settings. So there's an initiative that's been piloted in hospitals, a number of hospitals around the country in A&E, which is about talking to smokers whilst they're waiting to be seen and they're bored and a bit anxious, and actually you might think that's probably not a good time to try and engage people around their smoking, but actually it seems to have worked really well in all of the different hospitals where it's been piloted. So the consultant who's led on that has come and spoken to us, and we're thinking about how we might pick that up in our hospital trusts. There's an initiative called Stop Before the Op that's been around for a long time, but we've never really made it stick. So that's about people who've got planned operations coming down the line and trying to make sure there's really good pathways and offers in the system to support people to quit before they go in for planned operations, because we know that's a teachable moment for people, and it really has a very positive impact if you can help people to quit before they have an operation on recovery time, length of stay, infection rates, etc. So there's a couple of things in the sort of hospital world. We've also been successful in getting some additional resources from government around vape kits, which we will make available through the different treatment routes we have for smokers who want to quit. I know that the vaping issue is a bit polarised because the way that it's been allowed to be a sort of commercial product rather than a medicine, which is what I think it should always have been, means that children and some people who've never smoked have taken up vaping and got addicted to nicotine. So that's a real problem. That shouldn't be out there. But for people who are smokers, vaping is actually a very effective cessation aid. So we've kind of having to hold two different sort of realities on that issue. And then there's a London-wide collaboration that we are considering with all of the authorities across the city in relation to developing a more digital offer rather than people who want support to quit having to go to services, actually creating a digital offer that would enable people to use it whenever suits them. For people for whom that is a preferred route to kind of get support. And again, there's some products out there, apps that are well evaluated that I think we can put some of our money together across London and have a really strong offer there. So yeah, quite a lot going on the smoking front.
Okay, thank you. Neil and Steve, are there any questions? Councillor Cousins?
Morning, everyone. Sorry, my throat has got a frog or something in it. I suppose I'm in a medical place, so hopefully there's a doctor in the house if needed. No, thanks for the reports. What I wanted to raise about what's in the papers is the section 6, sorry, of the executive summary, what's in the yellow pages. And I know, Neil, you said that you'll come back to us with the outcomes, and you quite rightly said, yes, the outcomes are the important bits, yes. But I was looking at that tabulation, and I was thinking to myself, it's going to be a difficult one to come back on because there aren't any figures in it in the sense of you want to move from position A to position Y or something like that, or X, Y, whatever. So the number of children say that, whatever. I mean, and it applies to all of them. So, I mean, if you look at the first one, page 34, children and young people get the best start in life and can reach their full potential. It's a very broad ambition, and the impact you want to have, I can see there, but then I'm thinking, how on earth are we actually going to measure that? So I don't know. Just I was looking through them, and that's what keeps coming back to me. How on earth are we going to know we've gone from position X to position Y? That's it, thanks.
Okay, I'm happy to take that. So just to say that that's the ambition on the left-hand side. So the ambition is the overarching goal, of which there are 10. On the right-hand side is the high-impact activities, so they're the specific activities. So some of the activities aren't about the outcomes. So like family hubs, we've got that first one is we're going to have 4 family hubs. We've already opened 3. So you could go, well, that's an easy thing to measure. The reason you're doing the family hubs is to improve the outcomes for the children. So it's important you measure both. So sometimes the activity measure in that example is, have you opened the family hubs? Yes, we've opened 3 all on time and they're working effectively. But are we actually starting to see the impact of those family hubs on the outcome for the children and young people in the area? That is the important piece, and this is why it's the health and well-being strategy. It's the 5 years, so we're going to have to track that. So the good news is the intervention of, say, the family hubs is in place. That's good. The bit we will need to track is actually the outcome. So there is a lot of detail behind each of these. We've got a one slide which sets out where we're up to but what we felt for this meeting, because this isn't an operational meeting, this is a meeting to say the whole high-level strategy. And the idea is that we're more than happy to provide feedback at a detailed level here, but the Healthy Greenwich Partnership is the place that we'll review that. So I didn't feel that it was the appropriate place to bring all the detail here now. But if you've got particular areas you want to delve into, then we can absolutely do that.
Thanks. Can I come back, Chair? Yeah, it's not all the detail that's needed. I mean, just putting the figure 4, since that's what you're aiming for at the family hubs, would have helped me to see where the direction of travel. So just that figure 4, And I think just that, it might seem simple, but it means more to me now, because then I know what you're aiming for. So yeah, you reported that 3 had opened, but I didn't appreciate you're aiming for 4. Fair enough, I know I'm not regularly at these meetings if you've discussed it before. So just something like that would help with the information. So it's not about increasing it exponentially and making it complicated, but in that first one, just the number 4, and you can write it as a figure, would have made a big difference.
I mean, I'm very happy to take feedback and think about what is the best format to present back to this group. So I will take that on, thanks.
Matt.
Thank you. And thank you for the report. Lots of really good things happening. Could I ask, it might be for Neil, to say a bit more about the 100-day challenge to reduce cardiovascular inequalities? Who is carrying this out? Is this professionals looking for those people who may be at risk, who can benefit from, some intervention or advice about doing something before, before it gets worse? Have I understood that?
Shall I start off, and then Steve, if you want to chip in? So one of the reasons that cardiovascular disease overall was chosen was it's one of those areas that there's basically a primary prevention aim, which is to stop people getting cardiovascular disease kind of developing in people's lifetimes. Then there's the secondary care, kind of secondary prevention piece is identifying those people who may already have developed it, so who may have high blood pressure, for example, but making sure that then they're on the right medication to control their blood pressure and the lifestyle factors. And then there's the sort of tertiary side, which is someone might have had a stroke, a heart attack or whatever. So it felt that it affected the whole, everything from sort of that very early prevention stage to the treatment stage. And then if from a health and care system perspective, it affected what we needed to do on sort of strokes, carers. So it kind of was the whole health and social care system approach. So it was seen as a key priority for the Healthy Greenwich Partnership. So that's kind of how it came about as a kind of overarching priority. And what we then focused on is we got people to say, together and say, what would be the one thing that we could really work on together in 100 days and make a tangible difference? And so the 100-day challenge focus was on, we had a group of people looking at what are we already doing around blood pressure checks and how we can increase that. So Charlton Athletic Community Trust were already do a number of these things, but they were being mobilised in various places. So if you remember the Greenwich Get Together event in Charlton Park in June, at that event they were running additional sessions and getting people who were just there to do that. They were doing outreach events in particular communities. So we used the population health data around Plumstead and Woolwich, which is kind of where we've got a really high number of people who've got who are undiagnosed. And so we were doing some targeted work, particularly with the Glindon community. And so we had some community-based work as well. And then we also did work with employment. So one of the ideas, and so we did quite a lot of work up at Birchmere, and we worked there, and we went into other kind of the bus garage and other places like that, where you've got people in their workplaces. So it was a targeted program to try and find those people who potentially had high blood pressure. And through that process, I think we identified 3 people who literally we had to send to A&E straight away for immediate potential life-saving interaction because their blood pressure was so high that they were at risk of immediate kind of stroke or heart attack. Then there was a number of other people who had very high levels of blood pressure but just needed to be managed effectively, and making sure that those referrals were made. So, but what we've tried to do is make sure that we wrap that learning in. So been working with the public health team, and maybe Steve, you can say a little bit about how we're trying to embed that work with the kind of COMF approach going forward.
Yeah, so as Neil says, we kind of used this 100-day challenge to test out different ways of reaching people who might not present and, come forward for blood pressure checks. And we know that one of the reasons why blood pressure is such a risky issue for people who have high blood pressure is because you can walk around and have no idea that you have high blood pressure. A lot of people don't have any sort of symptoms, and so it's only through having the test that you discover that somebody has high blood pressure. So I guess what we'll be doing is trying to sort of take the learning from that exercise and sort of building that into our business as usual processes going forward.
Rachel?
Hello. I have two questions. The first one is around, on page 36, the lung health check program pilot. I just wanted a bit more information about the outcomes of the pilot, what proposals would be taken forward or not taken forward with regard to the learnings from that. Oh, and when we would expect that to be published or made apparent.
So the pilot is a national initiative, and it's basically designed to try to find people with undiagnosed lung cancers as early on in the disease process as possible. We know that for all cancers, finding it early is critical to better outcomes, but for lung cancer in particular, if it's discovered once people are symptomatic, the outcomes are pretty poor. So you kind of really need to find it before there are any symptoms at a very early stage. We also know that the majority of people who develop lung cancer have been smokers. So the it's called Targeted Lung Health Check program, is specifically targeting people who are at high risk of developing lung cancer because of the smoking behaviour that they've experienced through their lives. So it uses the GP registers, which contain information about people's smoking status, to invite everybody to have an initial triage, a conversation, and through that they will identify the people who are at highest risk, so related to age, how heavy a smoker they are, how long they've smoked for example. And they were invited to come to a mobile unit, which we had down in Greenwich, and we had an informal visit there. Some people around the table probably came along to that, where they have spirometry, so sort of checking the kind of performance of the lungs, and a CT scan to look for anything suspicious that might show up on the lungs. So Greenwich and Southwark in London were the two areas where this has been piloted, and it's happened in other parts of the country. We haven't got the data yet in terms of the outcomes in relation to how many cancers were discovered, for example. But we will be hopefully getting that fairly soon. And I know you've asked, Councillor, you've asked for a report on that to come to the January scrutiny panel. So we'll bring whatever data we have to that meeting. But it has proven nationally to be a very successful initiative, and there's already been a commitment from the Department of Health that it will turn into a national programme that covers the whole country, like breast screening, cervical screening, bowel cancer screening. So that will be something that is rolled out over the next few years across the country as a whole, which I think is it will be a really positive addition to the cancer screening programme.
Did you have a second question? I thought you had.
Yeah, second question I think is probably a little bit more complicated, but it regards the consultation you mentioned, which was due yesterday, which we were putting forward a view about the ban on younger generation buying tobacco. I have concerns about this because I have a background in equality legislation and equality campaigning, and once someone is over the age of 18, you really can't discriminate in the sale of the goods and services between someone who's 20 and someone who's 21. When you go into a shop and you say, well, I can't use age as a discrimination when I'm providing a service which is selling tobacco. So it seems to me that this proposal would be legally challengeable. No one seems to be talking about this, but once that generation are over 18, you can't use age as a means of saying what they can and can't buy in a shop if someone else is entitled to buy it. So I just wondered what our position on that is and in what capacity we replied to that consultation, and what our position was.
I'm sure there will be many people who make that point as part of the consultation, not least the tobacco industry. And, you know, I take that point. I mean, my feeling is this is such a pernicious substance that is still so widely used. If it was invented tomorrow, it would never be legal. And that measures that are about trying to phase out tobacco use in our population are really important, and fiscal measures have always been more important than just education. Education alone doesn't change people's behaviour very, very much. So, you know, completely take your point, and we'll see what comes out in the wash when they consider all of the responses, because some of those kind of legal issues will need to be addressed as well. So I don't think we have responded specifically as a council, although networks of councillors led by the lead member from Lambeth have sent a letter and responses, and professional associations like the Association of Directors of Public Health have sent in responses. I've provided responses from a public health perspective myself, and you know, we've been encouraging all of our staff to do the same. So we'll see what comes out the back of that.
Go on, Anne-Marie.
Thanks. Just to come in on that, there is already a process, Challenge 25. Now, somebody can go into a shop and they don't actually look their age. I'm in my 60s, I might not look my age. So you can imagine, I know, I just don't. I know, my 30s. Now, somebody can go into a shop and they are in their 20s, say, but they look as though they're teenagers. So the poor shopkeeper, I mean, poor in the sense of, you know, how on earth do you know what somebody's age is actually committed under the licensing agreement, some of them that's got that in their restrictive sort of covenants and so on. They have to challenge that person and say, well, to me, you look younger, because the person will say, no, I'm in my 20s, whatever, and they have to show ID. Otherwise, they have to not. That's what they're supposed to do. They are not to serve that person. So in a sense, there's already a sort of a uncoordinated, and it's left to the shopkeeper without much guidance to have to make some sort of a gut feeling judgment. There is a law that says you must not do something. Now, how are they to meet that? Because when the police or the local authority does their young people tests, invariably, and I just had one about a couple of months ago, and I don't sit on the licensing subcommittees often, where it was a shopkeeper in Plumstead, been going for decades, not a new business, and they were caught on a sting selling to 16-year-olds. As far as the shopkeeper came back with the usual, well, we thought the person was older. It was clearly a very young-looking young person, and they didn't do the challenge, which they supposed to do. So I suppose the reason when I heard that, I didn't say anything, because to me, if anything, the shopkeepers who are signing up to this probably need guidance. So there's probably a need for some sort of more coordinated and eventually official approach to how these things are being done, because the shopkeepers just left to themselves at the moment, and invariably a lot of them are being caught selling to underage, under the legal age, and then effectively they're being criminalized. So if we can prevent it more, it would help. But you are right, it's how it's done and what will be done. As Steve said, we'll see what comes out in the wash. But I doubt it's going to be very easy. It's not going to be an easy ride. Thank you. Could I take the opportunity to ask Steve another question, though? Yeah. Changing the topic, the subject, we're going to, you said that it's noted, I mean, I said what my age is, so this is one of those things that never change year in, year out, that teenagers, young ladies moving into young adulthood, that teenagers drop out, females drop out of sports. And I'm thinking to myself, well, we all know that menstruation is killing us at that age. Isn't that part of the issue? So let's just face, you know, the bull head on, grab it by its horns and deal with it. To me, that's, and I've had 2 girls, and that's the biggest hurdle. It's a nuisance. We all have to go through it, but I can assure you many of us don't embrace it and say, oh, I'm looking forward to next month's episode. So it causes a lot of problems. And in my day at school, I don't know if they still do it in schools, we had sports and then we had to shower off and all that sort of things. There were certain times of the month, I'm telling you, half of us was away. No way. Can't be done. But I mean, I don't know how they do sports these days. Probably send you home smelly or whatever. I don't know. You know, you don't do shower. Do they shower it still? But that was how, you know, we got down to the bare bones of it. Couldn't do sports. So if it's still the same thing going on in schools and other places where young girls, teenagers going through that sort of thing is meant to somehow fit in as though nothing's happening, it won't work. You've got to address that and be very upfront, be very normalized, but this is how we deal with it. Oh, this is, you know, why sports is actually good for you, because it's, if you get pains, the sports are actually very good for you. So I'd go for a walk with my girls. To this day, the 27-year-old one still expects me to rub her belly. You know, you've just got to just deal with it. It's what happens. It's life. Yeah? Thank you. I hope that helps.
Thanks, Anne-Marie. All right, okay, so thanks for the report. To Anne-Marie's first point, I do kind of share some of it. It would have been nice to see a little bit of, not, I realise it's very high level, but a bit more detail in some of the numbers, because, you know, I didn't know the numbers with the hubs too, was really. And a question, so I know it goes to the Healthy Greenwich Partnership. So at that meeting, is it a much more detailed report? And plus, are the papers for that meeting public? I know the meetings are technically sort of public. You can go to them, but I don't know if the papers are.
Yeah, so we don't always meet, not every meeting's in public, but so the meeting in November wasn't in public, the meeting in October was, so I think this one came to the November meeting, but yeah, the papers are available. And it is much more detailed, yeah. So there's basically, for each of the lines on here, there's a one side of A4, and then behind every side of A4, there's multiple bits of information behind that. So I think I just try to keep this at a high level, being this is a strategic boards and want to give you an overall update. But if there's a desire to go into the detail, what I suggest, I mean, part of our topics, like so today we've got suicide, you know, that is one of the aspects that sits within there. So it's about drilling into the detail, and maybe as part of our forward planner, we can kind of go through that. I'm more than happy to share the papers.
Yeah, just to say it's quite interesting, this discussion, because the points about having more detail and rather than just descriptions of activity, some sort of indication of outcomes was also raised at the Healthier Greenwich Partnership. And there was a bit more detail there, Neil. I wouldn't say there was a lot more detail there, but I think the problem is it's such an enormous piece of work, and I think you're absolutely right. It's about bringing very specific papers back here where you can go into much more detail on a sort of a case-by-case or topic-by-topic basis.
At the risk of extending the conversation, I think we also talked about the health and well-being strategy having some key performance indicators, because I think it's great to see there's activity going on against the kind of the outcomes, but the worry is in 3 years' time, we find that actually that was the wrong activity. So it's kind of just having some indicators at some point in time so that we actually do know that that is the right activity that is having an impact. And I think that was some of the discussion. And I think there was, Steve, you did say that we're looking at indicators and we'll be bringing them.
sorry. Next item is item 6, Greenwich Suicide Prevention Strategy 23 to 28. And Robin, it's your go.
Have I done that right? I have. Not familiar with these microphones. So thank you very much. Yeah, just to introduce the purpose and nature of the document that has come for agreement. This is a high-level kind of framework for future action around suicide prevention at a borough level. So absolutely acknowledging all of the points that have been made about the previous paper in terms of specificity of actions and outcomes. That will be something that will be developed in the new year through the refreshed suicide prevention partnership if this framework is agreed. So just to acknowledge, this is setting the scope for suicide prevention activity over the period ahead. So I suppose I should say something briefly about the kind of context. I know people have had the paper, probably familiar, but in Greenwich, we have not seen an increase in suicide deaths. There's indication of a possible decline in the most recent data. And that is somewhat better performance than we see nationally and in London, but we absolutely need to recognise numbers are small. We're talking about approximately 15 deaths a year in Greenwich. So there is a variability to the numbers that we'll see. And I think what we can say is we're not seeing any evidence of an increase. So this new framework is broader in scope than our previous suicide prevention strategy. It was developed through a engagement process with quite a lot of stakeholders this year, and is taking into account the quite extraordinary circumstances that we're living in at the moment. Cost of living crisis, international events, the legacy of the pandemic. So what stakeholders wanted to see in this version of the strategy is an acknowledgement of the wider things that are going on in society and that the local system and community are doing and dealing with that contribute to suicide risk. So what we will see following adoption of this framework, should it be adopted, is really looking at that breadth of existing activity and things that we need to move on that contribute to the suicide prevention agenda, pulling out what we can helpfully monitor and present back to give us an understanding of what's happening around, say, economic pressure, which is arguably the biggest relevant driver of suicide risk at the moment, looking at the very specific actions that we can take and where we can support our partners. So there's an element here that's around mental health services, which is an important component. Obviously, there's been a lot of really positive developments in that context through the Plumstead Greenwich Mental Health Hub that Neil was talking about. There are some clear kind of challenges that we need to get through, I would say, in terms of training, for example. We've made really good progress in some areas at a community level and within local authority and Oxley's in terms of offering training. Greater difficulty, say, in accessing primary care workforce are important, but also actions like the Greenwich Mental Health Hub are helpful with that. Really want to push forward and increase our communications approach around suicide and mental health and well-being. We've had an ongoing program of communication on this topic and mental health more generally with the population. But what we recognised and really heard through the development process was about the range of people in the community, in the voluntary sector, who have got insight, have got things that they're delivering that are relevant to suicide prevention, but don't necessarily want to be involved by sitting on the suicide prevention partnership. So what we are suggesting here is taking a kind of developmental approach to building a kind of coalition, a community coalition around suicide prevention that allows different people to be involved and contribute to the agenda in different ways. So that might be by sharing insight that they've got for what they're seeing within the communities that they're engaged with. It might be about getting better signposting and navigation of people towards support in the community. So that's going to be kind of a key thing that we're working on. And there's also some important developments within South East London. So in the kind of self-harm agenda, looking at getting a self-harm pilot off the ground in Queen Elizabeth that will enable us to respond better to people who we're able to identify as experiencing more serious self-harm and provide better support to them. So it's a very broad set of things. I think really, really welcome views on anything that isn't kind of captured in there, and thoughts on how we can drive that forward. But as you see in kind of the next step section at the end will be bringing that wider partnership back together, identifying task and finish groups, and agreeing kind of year one priorities for the kind of specific deliverables. Anyone want to add to that?
All right, thank you, Robin. Joy.
Yeah, just absolutely welcome the strategy. I think it's a really important piece of work. And although, as you say, it might only affect 15 people a year in Greenwich that commit suicide, I think, again, in your report, you point out that it's ripples in a pond, and it has an enormous impact on families and communities, and in some cases whole neighbourhoods. So I think this is an absolutely vital piece of work. What I would say is that I would have liked to have seen more emphasis on support for those affected by bereavement, because when I looked at this report, essentially it looks like you're just going to do sort of better signposting. So there's not going to be any particular investment in more services or more support for people affected by bereavement. It's more around, you know, just getting more information out there. And I hope I'm completely wrong about that. So I'll leave it to you.
So the action that you're seeing is indeed about signposting. But what we're signposting to primarily is a new service which we have advocated for and helped develop in South East London, which is a bespoke, reactive, outreachy service called the South East London Suicide Bereavement Service, which is delivered by BLG Mind and SLAM for South East London. So that is actually a really comprehensive offer. So people accessing it can get sort of like psychological counselling, chaplaincy, also practical support with navigation of life following a death. Because for anyone who's been unfortunate enough to experience anything like this, if you lose somebody to a crime, you will receive really, really comprehensive support through a police liaison officer. If at the moment that they clarify they think it's undetermined intent or probable suicide, all of that falls away, and it's a really, I have borderline had to do this, and it's a whirl, anything involving the coronial process and so on. So there is expert practical support available through that. So I think it's really, really good. It also links in with the real-time suicide surveillance system, which we mentioned in the report, which is another new South East London development that we've been able to kind of push forward. That means that where next of kin or witnesses are identified by emergency services, they will be contacted directly by that service to offer them, repeatedly in fact, to offer them support. So yeah, it's a really important and vulnerable group. There is increased risk of suicide if you lose somebody to suicide, and certainly of kind of poorer mental health. We can, when we come back with kind of detailed action plans and kind of outcome tracking, we can absolutely provide information on that service. It's a kind of independent, quite robust program with quite a few staff. So, yeah.
Matt.
Thank you, Chair. Thank you, Robin, for your presentation. Could I ask you to say a little bit more about where it says new mental health practitioner roles within primary care networks? Would that be a person working in every GP surgery, or?
So that's a reference to the ARRS. I hope I can get that acronym right. Neil, do you want?
Additional Roles Responsibility Scheme.
Yeah. Yeah, exactly. Yeah. So kind of in that between primary care and secondary care space, you've got the New Greenwich Mental Health Hub, but you've also got additional roles funded through this scheme, which includes mental health, a kind of range of mental health practitioners. So we've kind of got two elements of that bridge gapping or primary care kind of plus support available, which helps to address the kind of acuity, I guess, of people before they receive support. So it's earlier intervention and support, kind of hopefully pre-crisis for people in primary care.
Sorry, so it's a service that might be available for someone that the GP wants to refer into secondary care, but obviously there's a waiting list, so they can see the practitioner in the meantime, or is it stepping back from secondary care?
So I mean, part of the model of these roles are they're actually part of the primary care team. So say someone comes, you know, they've registered with a practice, they want to see someone, but it's clear that it's relating to their mental health, that within the actual GP practice, there's a mental health nurse working, and there's ones partnered with each of the primary care networks of the groups of GP practices. So there's not necessarily someone every day in every practice, but there are roles that are allocated. Those roles are recruited via Oxley, so they're provided by Oxley, so they've got the clinical supervision and all the kind of professional development and support. I met with a few of them the other day. There's some really good, capable people, and basically what they're doing is actually working as part of the primary care team, so you don't need to refer to another bit. They are actually part of that team. So not only are they helping in terms of the direct individual patient care for people coming into the practice, but they're also there. They can actually support the practice staff around how to manage some of the situations, because very often, you know, if you can imagine you're, I don't know, you want some tax advice, but you've got a friend who's a tax advisor, you'd go and ask them, you know. So the idea is that you're part of the team, so they're part of that clinical team of multi-professionals that sits in GP practices, so that helps strengthen the response, not just to the cases that they directly see, but also they might say, well, I saw this person, what would you advise I do? So it's strengthening that support.
Thank you. I perhaps should make a declaration of interest, actually, because as my role at campaigns manager at Help for Heroes, I did work on a project to campaign for local authorities to include the armed forces as part of their suicide prevention schemes. I just wanted to ask, in September, there was the new 5-year sort of cross-sectoral England plan. To what extent does your refresh fall in line with the England-wide suicide prevention plan? And, you know, is it for, you know, how is it following that similar structure?
This continued to be developed following the arrival of that strategy. So particularly if you look at the kind of existing work elements within the priority areas, you will see some of the more relevant things from the national strategy in there. In terms of kind of alignment, it's not with the national strategy that you would expect to see kind of structural alignment at a local level. One of the commitments in the national strategy is that they're going to look again at the guidance that is issued to local areas to help them structure suicide prevention work. So we definitely need to keep this strategy and approach dynamic, because we know that the situation can change. We know that the kind of phenomena, the numbers and our understanding of them can change, and we know that the kind of strategic context will shift over the life of the strategy. So certainly, as and when further guidance for local areas is issued, we'll look at that through the suicide prevention partnership, you know, report up into here and elsewhere. Certainly in terms of kind of specific things like the suicide prevention voluntary sector grants opportunity, that's acknowledged there, and we promoted that immediately through Naomi and the kind of Metro Gab's functions to the sector, and I know that there's been at least some bids against that. But yeah, there's a lot in that national strategy. A lot of it is national measures that will happen, you know, commitments for mental health ambulances, that kind of thing. A component of it is going to be around further research and evidence gathering. That's a real challenge for suicide prevention. I would say that the insight intelligence component and is not even across different areas. So in South London, we don't get access to coronial records, for example. In other areas, they do. So for us, definitely, until that changes, kind of further national research and evidence is really, really helpful, because we don't see all of the detail of our deaths that we could. But yeah, like, there's tons in there. Some of it is going to be kind of background to what we see, and some of it may be particularly like locally relevant, and we'll absolutely be engaged with that. And you know, I see the Louis Appleby, who probably like kind of led on drafting that strategy every couple of months through structure. So we've got good links in with that, and to be kind of prompted on anything we might miss in terms of that really, really long strategy that's been developed for England.
Okay. Anyone? Okay, Anne-Marie?
Yeah, what I wanted to just check with this is to, I suppose for me, I'm looking at, the title is a difficult one, suicide prevention. So immediately in my mind I thought, well, great. The task is to get ahead of me wanting to commit suicide. So it's almost an impossible situation. The numbers in Greenwich are so low. I've noted the actions, and to me, I'm still not too sure how, because it's mainly men, young men. How are we going to get ahead of vulnerable men who one day, or a man who suddenly gets up and say, this morning I'm going to go and hang myself, or do one of the typical ways of death, and I'm not seeing how we're going to do it. I suppose it's the way I'm analysing what you've presented. It's very specific, so you know the group, you know the choice, popular choice, but I'm not sure whether the actions are too scattergun. It's very general, but it's post, it's after I can't see how you would prevent me if I got up one day and decided that's what I was going to do. Thanks.
Thank you. So I think you do hit a nail on the head, which is that at an individual level, suicide is extremely difficult to predict, and in fact, so difficult that NICE have recently clarified that clinical providers shouldn't be trying to. They need to move away from doing suicide risk assessment because it's so inaccurate, and it actually leads to the opposite of the intended effect, which is, well, do a risk assessment and say, okay, like kind of only moderate risk, so we'll respond in such and such a way, but it's so unhelpful and unpredictable. So in terms of that, for an individual, what can we do to reduce the likelihood that they end up taking suicidal action? Number one, and it's why we've made it quite a broad set of actions to really recognize this, is suicide is, in some kind of ways, like the very tip of the pyramid of distress and lack of well-being. And that actually, the more that we can do that addresses the determinants and the drivers of why people become very distressed, be that providing earlier intervention before people get into crisis, which is what some of the earlier discussion was about in terms of the Community Mental Health Hub, the Greenwich Mental Health Hub, the ARRS roles, and what progress we need to make in terms of training for primary care workforce. There is the it's not before somebody becomes suicidal, but the intervention when they may be about to become suicidal is important. That's what a lot of the suicide prevention training is about. It's about being able to recognize, actually, I've got reason to be concerned about this individual. Now, we'd all love it if 5 years previously somebody had intervened and that person's life was on a better track. But actually, we're fortunate with suicide that, unlike lung cancer that Steve was just talking about, right up until the moment somebody takes a fatal action, interventions are really effective. And that just interrupting that can save somebody's life, because people often move out of that, the really severe mental situation they're in, where they're going to take action and do something. So the more people that we can kind of mobilize to realize there is something that I can do and I can be confident about it, the more we can intervene at the last moment, which does save lives. I think at the moment we don't know how to identify that somebody is on track to die and intervene much earlier, which we love to see, and I think is kind of what you're thinking about. But things change. Things change. We all see the era of technological change that we're in. It may be that in periods ahead, things like AI contribute to something like that, and we'd like to know. And I'd say just like the final thing was in terms of you're right. It's predominantly men. Sometimes the numbers can be a bit confusing. Suicide is a much bigger contributor to deaths among younger people, but that is because they're not dying of other things. The sort of bigger numbers remain in middle-aged men. A bit younger in Greenwich than average, but in that sort of late 30s onwards. And white is the other thing, and I would absolutely acknowledge that as a challenge for us. White men are probably one of the community groups that we most struggle to engage with, particularly if people aren't in faith communities, which is a protective factor of its own. Definitely something that we want to try and do through this is try and reach into some of those communities where we know the risk is, and just try and drive some better understanding of how we can help people in general. And I think that's part of the lesson around this. There are some very specific things that we can do about preventing suicide, and then there's everything else that is kind of determining people's situation, and we need to obviously continue to strive to do that as well as we can, which is what, you know, the whole health wellbeing agenda is about, really.
Fine, so if I'm understanding, it's a broad brushed approach in the hope of getting to people, but what about workplaces? Do you feel the actions proposed, or well, they're not specific action, but the broad intent will get into workplaces? Because I'm just sort of thinking there's a lot on community groups. That very demographic that you've said is not going to be in a lot of these community groups at all. So is it the workplaces? Is it the sports halls? Is it because it is weird. I could be with somebody today having a nice cup of tea, and then I can get up and hear tomorrow or on the way home that they did something. It's not easy. But yes, if you can get the information into people's heads well in advance, but you have to be in the places where they are. Thanks.
Yeah, absolutely. So I suppose on the sports front, we do have a relationship with Charlton Athletic, which I would say probably our best reaching white men tool at the moment. Yeah, absolutely work. Yeah. But in terms of the kind of people that we can deploy, sort of faces that people respond to, I guess, that it is helpful. Yeah, I mean, we will absolutely be trying to use our business networks and so on to push comms and training out. It is kind of challenging in Greenwich. I have done quite a lot on the sort of stigma front in the past. We've got such a wide number of kind of small, medium enterprise businesses in Greenwich, which is kind of like does make it a slower process.
Could I just add, it might be something for the business cabinet member to take up on board, and I'll certainly mention it to the Business Crime Reduction Partnership that we've set up as something to take on board. Okay, thank you.
Absolutely, yeah. I think what's important is a whole system approach to this in different portfolios, and it's not just doesn't just sit in health. Rachel, thank you, Councillor Cousins.
Just a point on the section on the armed forces. I think is a bit limited. Kind of saying there isn't a risk above the population as a whole of being in the armed forces or a veteran, which on the surface is true. But the trends within the veteran community tend to run quite differently. So it's actually those between the ages of 18 and 26 who haven't been to war, who are in the other ranks and leave service in less than 6 years, are at a 3 times higher risk than the population as a whole. So it's not the middle-aged men that the population as a whole, it's those who've gone into the armed forces, not had particularly long nor successful careers within it. And conversely to what most people think, actually going and being deployed abroad is a protective factor. So I just offer services, there's a lot more I could help on that particular section if you were wishing to engage with us.
Yeah, it would be really great to kind of look at that evidence. And I think would acknowledge that while the data doesn't show increased risk for veterans, it does for, testing myself here, I think younger male dependents of people in the armed forces, yeah. So, yeah, but absolutely would love to, look at who our best links are. We have been engaged with SAF around it, but yeah, love to. Thank you.
Thank you. Well, before you go, we thank you, Robin, for this report, and also it's really good to see the words of Lade in this report too, because I know she's a huge advocate of suicide prevention, and she has her own organisation that she works with. Right, so we need to approve this this strategy and framework. Am I members? Yes. All right. Cool. All right. Thank you. All right. Yeah. Well done. Next, it's thank you, Councillor Cousins. Thank you. All right. Next is adult social care workforce update. Nick.
Thank you.
Chair, sorry, I'm going to attend these other meetings as well.
It's on female genital mutilation.
Okay.
In which case, then perhaps I will stay. I can forego that meeting if this one's more important.
Okay, thank you. So you've got the report here about the adult social care workforce. It was actually a report I was asked to produce for scrutiny, so apologies to colleagues who've seen this before. But if I run through the key highlights, I suppose, from the report. In 4.1, what I've laid out is, I mean, often we talk about the adult social care workforce almost as a homogenous entity, but actually what I've done in 4.1 is broken down the various roles within the adult social care workforce. So you have some of the roles that we have and employ within the council itself, social workers, occupational therapists, but then also the wider extended workforce, which for particularly for adult social care is where most of our investment is, most of our funding goes, and most of our focus is on in terms of making sure that we've got a sustainable market of services for people to utilise and be able to support them with. So I thought it was important just to break out what those roles are, and very happy to answer any questions about those if you have them. I then move on to talk about the national picture, and Skills for Care produce a really useful State of the Adult Social Care Sector report, which they produced back in October, to give a state of the social care workforce. So you'll see from that the challenges, that include a significant number of people leaving the workforce, this is national figures, but 400,000 people leaving, with around a third of them leaving the sector altogether. The Skills for Care report for this year does highlight 5 factors that are key to retaining staff, which probably won't come as any surprise to you in terms of what they are, but they're listed there in terms of being paid more than the minimum wage, not being on a 0 hours contract, being able to work full time, being able to access training, and having a relevant qualification. So the Skills for Care report is, I think, really useful in terms of giving that national picture. And there's a lot of data in there, which I won't go through line by line, but I'm very happy to pick up on any questions or queries you have in that regard. I think the key point towards the bottom of page 86 is that national projections show that we'll need 25% more posts by 2035 if the number of adult social care posts grows proportionately to the projected number of people. So that's in the region of 440,000 additional posts. And I think that prompts, when we're thinking about that, a question more strategically about how we approach our adult social care and health workforce, because we know the financial constraints that we have and the workforce constraints mean that it's very unlikely that we'll be able to deliver that amount of additional workforce. So what can we do differently in terms of thinking about more integrated roles, more workforce, new roles within workforce? And we've done a lot of work locally around integrated teams, such as the JET team, for example. What more can we do in that regard? Can we do more in terms of our home care arrangements and how they might support district nurses? So that work's ongoing, but I think that's really important probably to note given the quantum of the challenge. Moving through then, in terms of the regional picture, which picks up at 4.3, this is really just a kind of a filter down from the national picture, which shows the challenges in the sector. So starter rates falling and turnover quite static, and the fact that we've got quite a number of unfilled posts as well. So again, a pretty stark picture in terms of the regional picture there. And again, it gives there the regional estimate being that we'd need 69,000 staff across London, required by 2035 to meet the challenge. So that I think is the national and the regional context. In terms of the Greenwich picture, we have got workforce challenges in Greenwich. They relate to recruitment and retention challenges in respect of social workers and occupational therapists. There's a growing reliance on agency and interim staff who are really valued and necessary, but nevertheless we'd want to invest in permanent staff going forward. And I've included an appendix there which provides some additional detail about the Greenwich workforce profile and challenges, which again I'm happy to answer any questions about. In terms of our local strategy, it's to focus on three key things: career progression, advertising social care careers and the progress of the strategy and recruitment, and then development and recruitment and retention of the unregistered workforce, e.g. social carers. So there's a range of actions we're undertaking to address the workforce challenges, and I've detailed them from page 88 onwards. I think we've been really pleased to launch in the last couple of years our adult social care apprenticeship scheme, and we've taken some learning from children's colleagues in that regard, and have worked with children's colleagues on some of that particular piece of work in terms of apprenticeships. And I think that in regards to that, we've got this year 6 apprentices. There's obviously an investment, and it takes time and support from the teams, so we need to make sure that's carefully calibrated, but we will be recruiting a further 6 in September. I think the advantage we've got in Greenwich in terms of our adult social care workforce is we've got a large number of social care assessors who are not qualified social workers, but very long-standing, loyal social care staff who are very, very well experienced in the borough, know the borough, and offering them the opportunity to become qualified social workers is really something that we need to make sure we maximise. And we know that within that group of workforce, there's a real desire to be able to move up in that way in terms of career progression. And because we've got a larger number than other boroughs, we're in quite a good position there. So that's something we're really focused on. You'll see some other measures in there as well, which I won't go through in one by one, but there's a lot of focus that we've got at the moment on making sure we recruit, retain our social care workforce, and also that the work that's going on corporately around developing our corporate workforce strategy gives us some of the tools and levers that we can utilise as well to make sure that we ensure that Greenwich, not just in terms of adult social care, but Greenwich as an employer is really attractive to people who may want to join us in social care careers. The last part of the report relates to the external provider market. So it focuses on the fact that we've got from 4.5, we've talked about the social care workforce working with providers external to the council. So again, given the national context and some of the challenges there, and then also some of the detail around some of the funding that we've had been made available from government recently in terms of market sustainability funding that we pass on to providers to ensure that they can operate in a sustainable way. Although I would say that the level of funding that we've had, both from the sustainability funds and others, has reduced year on year. So it's more challenging and doesn't give us the required funding to meet the gap. So the workforce challenges within the sector are insufficient suitable applicants, current workforce lacking in morale, providers stating they're unable to offer significant career progression, and this burnout of workforce. So there's a lot we're doing locally to address some of those issues. So we've got the working with an organisation called Care Friends, which is a recruitment channel, which is key in supporting potential candidates in the local community who are not actively job seeking. We're supporting through training and development for managers, also through a Health Innovation Network and Skills for Care, and our home care model, which Neil alluded to earlier in the first paper. We've expanded our reablement criteria and eligibility, and that's become more of a therapy-led service. And so by developing that sort of model, we think we're developing more options in terms of the career options for people who might want to, work between home care, reablement, and then, into other sectors in the social care sector. Throughout this, we've noted international recruitment, and that has been something which has nationally, obviously, bolstered the social care workforce. It hasn't come without its challenges to the individuals that have been employed, but also through some of the registration processes. And obviously, recent government announcements reflect on, the fact that we might not be able to rely on as much international recruitment nationally as we have done with the decision about dependents. But I think we've always had quite a tentative approach locally to international recruitment, making sure that we balance it off and are proportionate about the amount of international recruitment that's undertaken and sustainable versus the need to try and engage and employ local residents in the care sector. So I think at that stage I will finish and hand back to the chair, but if there's any questions, really happy to answer them.
Okay, Rachel and Naomi. Go on.
Thank you. I'm only going to put one question because we've already seen this paper at scrutiny. But since then, obviously there's been a huge announcement about international recruitment and the increase in the salary level, but also the restrictions on bringing dependent family members. I appreciate this is a very big question, you might not be able to answer it, but to what extent do you think that's these new announcements and new regulations going to impact our ability to fill these vacancies?
I think they inevitably will. I think, let's say, because in terms of the minimum salary, the health and care workers will be exempt from that increase in terms of the minimum salary. So that in that respect, it's a mitigation. On the flip side, though, the ban on care workers bringing family dependents to the UK, I think will have a real impact because hearing a lot of the feedback from care workers and the aspirations of some of the people that come to provide care, they'd want to especially because lots more people are travelling from further away, I guess, than traditionally was perhaps more of an EU type migration. That I think is going to be a threat nationally in terms of the social care workforce and the element of international recruitment that you rely on. So I do think that's going to have an impact, yeah. What I would say is, locally, what's quite challenging to get a grip on is, even though we work very closely with our providers, and we won't always know how much international recruitment has been undertaken and how much they're reliant on that. We do know that through some of our monitoring work, but we don't have a full comprehensive picture of that, which is something we continue to work on. So it can be a bit of a challenge.
thank you, Chair. This has just triggered a few thoughts around the voluntary sector, and it's a workforce. Yes, there is some of that workforce you will know about because you commission and you fund, but actually a substantial element of it you probably don't know about. So my last set of stats showed that we employed around 9,000 people in the sector. It's a guess here, but I'm guessing between 1,000 and 2,000 will be doing some sort of social care work, whether it's a drop-in, whether it's befriending, whether it's lunch clubs, whether it's daycare, supporting people with mental health issues. And they're coming in probably on a relatively lowly paid, obviously paid at minimum wage. The sector is probably struggling in terms of recruitment even more than the statutory sector, and whether there's any link up we could make with you where there's kind of some sort of career progression. So you go in at this early stage, and it may be that you're going in because it's a part-time, 1 day a week, which isn't what you can provide, but over 2 or 3 years you can develop and then maybe move into a better paid statutory sector job, and which might help the voluntary sector in terms of its recruitment, but also might help you in terms of finding people down the line. It's just an idea that has popped in my head in the past 10 minutes.
No, I think that's a really helpful point, Naomi, and I think there's a couple of things I'd say. One is that we are committed to working with the sector to develop more trusted assessment type models where we know that, as a council or in the statutory services, we don't necessarily always, people find it more comfortable perhaps to approach, someone within the voluntary sector rather than the statutory sector. So the trusted assessment model is certainly something we'd want to and are starting to work on with, colleagues and would certainly be keen to talk to you about. I think in terms of the crossover, it's a really important point you make about the kind of crossover between, the type of voluntary sector support that's provided that kind of mitigates or means that you don't need as much statutory support. And I guess in that area, again, it's how we can make sure our model of working with residents around their assessment and support plans in that trusted assessment model could be developed. And I think as a byproduct of that, then we would be looking at the workforce itself and where those career, paths might be further developed. Because as I said at the start, we've obviously got a national workforce crisis, so we need to look at different solutions. So I'd be really grateful for a follow-up conversation on that.
Yeah, I think that's a great idea, Naomi, and really just to echo that. So as an example, in the last year, we've worked with up to 100 volunteers just in Health Watch Greenwich. So that's volunteers, interns, work experience, placements, many are sort of short term. But if there was a way in which we could share a pathway, obviously it wouldn't be suitable for all, but there might be some who might well be interested because they've sort of put their toe in the water with sort of Health Watch and learnt a bit more about the health and care system, and some of them might well be interested in finding out and pursuing more career options. But at the moment, I wouldn't even know where to send them to and what the options are and where the opportunities are. So, and I think there are probably many organisations across the sector like us that potentially could be sort of guiding and signposting and encouraging people to consider that as an option. So.
No, I think that's really helpful. And again, we have got some infrastructure in place. We've got health and wellbeing, careers hub, which has been developed across South East London. But the fact that you're not aware of some of these things suggests that we need to do more about getting that message out there. So really happy to link up on that as well.
I'm just thinking, I'm not sure the Health and Wellbeing Board is the place to do all the workforce conversations, but I do think there's a really important conversation happening about inclusive economy and how we, particularly the generative economy, and how we work with the community voluntary sector, the engagement, etc. And there's a huge, all of the pathways we want to try and do. So I just think that piece of work is in development at the moment, and Michelle Rankin, as you know, is kind of leading on it. And I don't know if it needs to come back in here, but I think we need to make sure that the people who are around the table here are actively linked into that, because the opportunities are huge, and there's some real win-win-wins here. I mean, one example to highlight, only 8% of people with a learning disability are actually in employment. That means 92%, if I get my maths right, are in a place where they're probably dependent on services, which is obviously costing us all money, but also those individuals don't have some of the agency that you get when you're actively in employment. So there's the real opportunities, but it will require us to work quite differently in our businesses, and I think the community and voluntary sector has a key role to play, but it's how do we grow some of those. So I think there are some quite active conversations happening in the borough. We have got some good practice examples as well in the borough, but I think the opportunities to grow people at all levels going into health and social care careers, and the fluidity of moving people between them. And we've had some good examples during COVID of where we've done that. But it will require quite a lot of work. I mean, Eugenia Lee, who's one of our GPs, is doing some fabulous work on that kind of whole kind of employment workforce development side. So I'm not sure it will come back in here, but I think it's definitely something that the members who are around the table we should kind of actively work on.
Very good point, yeah. I don't know if you wanted to close, Neil? Not Nick, sorry. Let's go.
No, just thank you for hearing the report. I think it presents a lot of challenges, but equally locally we've got a lot of work that's been developed to combat those challenges, and the discussion today has been really helpful in, I suppose, surfacing some other areas that we can pick up on and work together on. So thank you.
Okay, brilliant, thank you. Right, item number 8 and 9 is informal feedback from March, informal board visit, and September's informal board visit. Okay, Steve.
So thank you, Chair. These are information items, really. Colleagues will know that in between the formal Health and Wellbeing Board meetings, we have informal meetings, which is relatively new, sort of part of the Health and Wellbeing programme. And at those meetings, we tend to go to different parts of the borough and hold them in different places and look at particular themes in depth. So obviously not every board member's been able to attend all of those, so we sort of routinely do a bit of a write-up and bring it back to the formal board meeting so that people who weren't able to be there can see some of the detail around what was discussed and where, etc. So at the last formal board meeting, we ran out of time and weren't able to take the feedback from the March informal meeting, which was why you've got 2 informal feedbacks in your agendas. So you'll see that we've already talked about the first one, the March one, which was where we went and saw the targeted lung health check programme in action. We also heard from the lead GP, Caroline Hollington, around and colleagues in my team around performance in relation to cancer screening and outcomes from different sorts of cancer and the stage at which people get diagnosed. So really sort of setting out the challenges and the opportunities for improvements. And we also heard about some of the things that are being done to try to make some of those improvements happen. The lung health check programme is one of those kind of new developments that should make a really positive impact. And then at the September meeting, we went to the new centre at Kidbrooke, which is a great integrated centre with health provision and other organisations based there, and heard a range of inputs in relation to mental health and well-being. So Robin talked about the emerging suicide work that's come today as the strategy that you've all agreed. We heard about different approaches to preventing poor mental health and promoting positive mental health, and also some of the work that's underway, again, much of which has been referenced in the meeting this morning around support for people experiencing mental health difficulties to make improvements in the service offer. So we will be planning for the next informal health and wellbeing board for March of next year. What we're trying to do is to get a little bit more ahead of the curve around a forward plan, both for the informal health and wellbeing boards, but also for the formal health and wellbeing boards. At the moment, we've been sort of planning them one by one, which is fine. But I think now we've got our health and wellbeing strategy / local care plan. We know the kind of priorities that we're wanting to pay attention to as a board going forward in relation to our agreed strategy. It would be good to get a bit more forward planning in train around the kinds of things that we want to bring to those formal and informal meetings in the future. We'll be developing some kind of draft forward plan proposals and involving people around the table through that process and kind of checking back a bit nearer the time. So that's all I wanted to say on that.
All right. Are there any questions? I went to the last informal one in Kidbrooke, and I thought it was really good, hearing about the work. Any questions? Go on.
Well, just I think they're really helpful things to do. I think there's in the formal meetings we have to kind of note formal papers, but I think in the informal space we kind of potentially have a richer conversation. So I think people's thoughts on what the next areas are, and I think the suggestion of looking at primary care and neighbourhoods is one of the things that we might look at as a next thing, because that came out from one of the last formal meeting as an area that people were asking questions on. So I think we're going to be looking at that.
That's good, yeah. I mean, I agree with you totally. I just think the informalness of it allows not only just to develop stronger relationship with the partners, but actually hear more in depth about what's going on. So I thought it was good. Go on, Naomi.
I agree, Neil. I just wonder with maybe one of the new children's hubs, that might be a good place to go as well. Yeah.
We've got a conversation this afternoon to sort of try and shape the informal agenda, so we can definitely add. So anyone's informal thoughts on, or thoughts about the informal, whether you're formal or informal thoughts, would be really helpful.
Anyone else? Any other comments? All right. Thank you. That brings to a close our December Health and Wellbeing Board meeting. Thank you, everyone. Thanks for your reports and contribution. Thank you.